All right, so now we're ready. We're going to pivot a little bit from science, machine learning. Now we're going to move into the challenging world of convincing the regulatory bodies that this is all valid science. And we know that this is a journey. We know it's very important in our field, and you saw in that very last talk where we're talking about the shear stresses inside of an aneurysm in your brain, and that's life and death. And so what we're talking about, obviously, is very real. And so this session is about how we can make sure that all of our great innovations make it through that very important hurdle in a cost-effective way, but also safe way. And we know that there's great opportunity for what we bring with these virtual twins, but we just need to know how to do it carefully. And one of the things that we've been very fortunate, because we've developed this very broad multidisciplinary community who all have a good understanding of their domain, but also a connection to the other parts through the virtual twin. We've been able to really build a good relationship, as you said, with the regulatory bodies. In fact, and I'll be talking today about a project that really goes back that we call the Enrichment in Silico Clinical Trial. Many of you who work in the field have probably heard this term a number of times. It's starting to become fairly prevalent in the vocabulary. Oops, I think it might have been on a timer. The term in silico clinical trial really refers to the idea of running that trial on the computer first. So we've talked about modeling a procedure on the computer first, but how about the entire trial? And so the idea is to go beyond just being able to, the idea of virtualizing a trial. So in the clinical trial world, historically you had to go into a clinic, you get your treatment, you go home, you do your business, you go back to get measured, and you have to go back and forth, and that's slow and painful, and the data's not very rich because you get data points instead of continuous flow data. And so now with sensor technology and other ways of monitoring, you're able to allow people to run trials to some degree in their own environment. But that's on real patients. So can we include the virtual patients in this concept of a virtual trial? Can we do the whole thing first? And how much of the virtual world can we introduce? And so I want to highlight, I'll go through a few things. I want to highlight a project that we're working on. My principal investigators from the FDA, Brent Craven and Kenny Aycock. Neither could be here today. Brent will be joining us virtually. Kenny joined us virtually at the last meeting. And so in fact, and I'm showing this from our last meeting in December, I've mentioned that once or twice before. At that meeting, we had a very detailed presentation. Kenny gave a very detailed presentation on the work we're doing, developing a playbook that I'll talk about a little bit on how you can actually run the clinical trial. I presented some of the background and the details. So I'm not going to go through it in the same level of detail now because that's recorded. So you can go online and view those presentations rather than having to go through it again today, so we can spend more time in a panel that will follow my intro here. And so I wanted to give a chance for some of the people participating in the trial or on the advisory team, which I'll talk about, to actually talk about it and a little more informally. So just so you have the background, I'm going to go very quickly through what the in silico clinical trial project, the enrichment project, is, so you understand what we're talking about. But really, it's an example that was really driven by a conversation that began with the center director, Jeff Shuren, as we were talking about how to drive the power of modeling and simulation into the regulatory process. He's a strong advocator to bringing the best science into the regulatory process, not simply wait and see what the outcomes are, but get ahead of the science, predict the outcomes before, so that by the time the trial is run, the reviewers already have a good mental picture for what to look for. They know what kinds of patients are in there, and that would be the foundation for maybe driving the review process. He talked about the progress they had made getting the review process down from an average of over 1 year down to maybe 9 months. And he said, but why does it take us 9 months to make a decision? Why can't we do it in 2 weeks? If we had all the information, if we knew what to look for, if it was all in one place, that's what I want. And there's no way to get from 9 months to 2 weeks by increments. We need to change our thinking. And that was the inspiration. Seems to be a timer in here. That was the inspiration behind the project, which we launched in 2019 to actually build an entire cohort. And you've seen some illustrations of that over the course of the last 2 days, focusing on how we could actually develop an in silico clinical trial. So let me just go through a little bit of what that means, how that could change the process. Because just running a clinical trial is kind of the end of a process. So you really can't think of it as an isolated event. You really need to think about it as part of a continual process. So if we look at the way medical devices or drugs are developed today, there's a cycle. It begins with an idea. It goes through some internal testing. You go through some laboratory testing, maybe some in vivo testing, animal testing, we heard about that. And then eventually you get to the clinic, you learn a little bit, you go back, you make changes, and that's very slow. And eventually you get to a point where you feel like you're ready to take it to the regulatory bodies, but you're not really sure. They're not really sure. You're not really sure. And as we know, less than half of the trials are successful as a result of it because there's too much uncertainty. And then you have to go back, review it, start the cycle over. And even when you are successful, we're still learning when you get out into the world and you expand behind the cohort that you chose, which is still a model for the real world. So often, too often, there are recalls or revisions. You learn, we have to change it. And now you go back and you start the process over and uncertainty builds back in. So what we want to do is have a process where it goes linear. And we've heard about the relationships or borrowing from what's been learned in aerospace and automotive and how they can fly an entire plane for the first time after it's in production because they've already done it and they've spent decades figuring out how to make sure that the physics is right, that we know that by the time they build that prototype, it will fly. And that's the goal that we want to get to. And the way to do that, we believe, is in these stages, before you get to the clinic, run the clinical trial, model the population, understand what you're doing. And we've seen some examples of how you can do that over the course of the last few days. And this project is really focused on, well, if we have the technology, how do we translate that into the regulatory process? How can the FDA reviewers or the EMA reviewers be confident that what you've done is credible? Today, they simply wait and they see, did the patient live or did they not? That's an easy answer. What we're doing is seeing if we can move that up front in the process and do better control over the entire process and take away the ambiguity. And so to run the trial, we brought together a very large population. We had executive sponsors from both our company, who is leading the technical work, and the FDA. We had advisory councils from the clinical community, from the scientific community, and from industry. They played different roles. We started with this community, who helped us choose the topic, which, as you've kind of heard, we chose not an easy topic. We chose the mitral valve. You've heard a lot about it. It's really the next frontier in helping to develop new devices. The Clinical Advisory Council made sure that the patient population represented real patients. The Scientific Advisory Council and the Industry Advisory Council, in the end, making sure that what we come up with actually is practical, you could implement it. And here are just some examples. You've seen some over the time. We developed a new parametric model. You've heard about it. You can just dial up the patient you need and generate cohorts kind of at will. And as you'll see and have heard, You can take these cohorts, train artificial intelligence to help you figure out what the right cohort population. And all those details are recorded. What the playbook does is it actually talks about how we develop credibility from the different models that you actually have to go through. The model of the patient, the model of the device, the model of the treatment, the cohort. There's multiple models. All of that is laid out. It's described. It follows the regulatory guidelines that were published, or in draft guidance that were published. So it's all available to you to understand how to do it. And then this is a kind of an example document of how to take that guidance document and actually apply it to a clinical trial. And so all of that is going to be available. At the last meeting, we had Ed Margresson, who's the director. He presented, and I include this quote because I think it's really it's a symbol of what the FDA is trying to do, is helping us and to turn great science into great regulatory tools. And that process is not simple, but it's important. And so again, I refer you to go and see the replay, and you'll get more detail on the trial and the playbook, et cetera.